Living with adrenal insufficiency means you already have a full-time job managing your cortisol. You take your replacement medication, hydrocortisone, prednisone, whatever it is, you track your stress, you adjust for illness, and then you add an antibiotic, or you start a new antidepressant, or you just buy a supplement at the pharmacy and suddenly your body goes into free fall. The math you've relied on stops working. The dose that kept you stable yesterday leaves you dizzy and exhausted today, or wired and unable to sleep.
And the immediate instinct is to think the disease itself is progressing, or that you miscalculated your stress dose. The piece that almost always gets missed, even by physicians sometimes, is that the amount of cortisol you swallow isn't necessarily the amount of cortisol your body actually gets to use. The medication you take doesn't just bypass the rest of your system. It has to be processed, specifically by the liver. And that processing speed can be radically altered by other things you ingest. That's what this My Adrenal Life article is unpacking. It's looking at the hidden variables in cortisol metabolism.
The feeling of being gaslit by your own treatment protocol. Because on paper, your dose is correct. You can look at the pill bottle, look at your chart, and see that nothing changed. But your symptoms are screaming that you're under-replaced or over-replaced. Let's get into the mechanics of why that happens. It comes down to a specific enzyme system in the liver.
The cytochrome P450 system, specifically an enzyme called CYP3A4. If you think of your liver as a chemical clearinghouse, CYP3A4 is the main processing line for a massive percentage of the drugs we take, including corticosteroids like hydrocortisone. Your body uses this enzyme to break down the steroid so it can be cleared from your system. It's a highly regulated conveyor belt. But certain medications act as enzyme inducers. They basically walk into the factory and tell the CYP3A4 enzymes to work double time. They speed up the conveyor belt.
So the cortisol gets broken down and cleared out much faster than it's supposed to.
Exactly. You swallow your 10 milligrams of hydrocortisone, expecting it to last for 4 to 6 hours in your bloodstream. But because you also took an enzyme-inducing drug, your liver shreds through that cortisol in 2 hours. Your blood levels drop, you start feeling the weakness, the dizziness, that bone-deep fatigue that signals low cortisol. But you're confused because you took your dose. You feel under-replaced because functionally you are.
And this isn't just a theoretical dip. The article highlights seizure medications as massive offenders here. Phenytoin, carbamazepine, oxcarbazepine, these are heavy-duty enzyme inducers.
They fundamentally change the pharmacokinetic landscape of your body. If you have adrenal insufficiency and you develop epilepsy, or you're put on one of these drugs for nerve pain or mood stabilization, the standard replacement dose of hydrocortisone might suddenly be a fraction of what you actually need to stay out of a crisis. And the scary part is how quickly that instability can hit. It's not always a gradual decline. Sometimes your usual dose just seemingly stops working within days of starting the new medication.
Let's push on the antibiotic piece, specifically rifampin. The article calls out rifampin and rifabutin. I've read that rifampin is such a strong inducer, it's actually used in studies to deliberately test how drugs are metabolized. How severe is the clinical impact for an adrenal patient?
It can be catastrophic if it's not anticipated. There are documented cases in the medical literature of patients going into a full-blown adrenal crisis simply because they were prescribed rifampin for an infection. Rifampin accelerates cortisol clearance so aggressively that patients who were perfectly stable on standard replacement therapy suddenly experience life-threatening drops in their cortisol levels. In some tuberculosis patients, starting rifampin actually unmasks an underlying adrenal insufficiency that hadn't been noticed before, sending them straight into an Addisonian crisis. The enzyme induction is that powerful. The liver just aggressively clears the steroid out of the blood.
I'm not sure that holds for every antibiotic, though. The article points out that antibiotics are a double impact category. We just talked about an inducer, but the infection itself creates a demand for more cortisol, which muddies the water.
That's the trap. When you get an infection, your body experiences physical stress. In a person with a functioning HPA axis, the body naturally pumps out more cortisol to handle that stress. So when a patient starts an antibiotic and feels terrible, the immediate assumption is, I didn't stress dose enough for the infection. They blame the bacteria. They rarely blame the pharmacy.
Right, you assume the pathogen is winning, not that the antibiotic is chewing up your hydrocortisone.
And to complicate it further, not all antibiotics speed up the conveyor belt. Some do the exact opposite. Chlorothromycin, erythromycin, these are enzyme inhibitors. They walk into the liver and throw a wrench into the CYP3A4 machinery. They slow the conveyor belt down to a crawl. So now the cortisol you're taking isn't being broken down. It's pooling in your system,
Leading to overexposure, which feels completely different. You take your normal dose, but because it's not clearing, it stacks. You get wired, fluid retention, trouble sleeping, mood swings, the symptoms of hypercortisolism.
Antifungals are notorious for this. Ketoconazole is a profound CYP3A4 inhibitor. It blocks the metabolism of hydrocortisone so severely that it can lead to a 2 to 4-fold increase in hydrocortisone exposure. It's actually used off-label to treat Cushing's syndrome because of how powerfully it alters steroid dynamics. If an adrenal insufficiency patient takes ketoconazole for a severe fungal infection without aggressively reducing their hydrocortisone dose, they are going to experience intense corticosteroid toxicity. Their blood pressure will spike, their blood sugar will destabilize, they might experience intense psychological effects, and again, they're looking at their pill organizer thinking, but I only took my normal 20 milligrams today.
There's something almost sad about that. The intense tracking, the spreadsheets, the alarms on your phone. You do all the right behavioral things to manage the illness, but the biochemistry is operating on a different set of rules behind your back. Let's look at antidepressants. The article calls this a nuanced category. Fluvoxamine is mentioned as an inhibitor of multiple CYP enzymes. Nuanced is the right word. Antidepressants don't have the universal sledgehammer effect that rifampin or ketoconazole have on cortisol metabolism, but they introduce a massive diagnostic headache. If you start an SSRI and you start experiencing insomnia, sweating, nausea, and anxiety, are those side effects of the new psychiatric drug? Or did the drug inhibit CYP3A4 just enough to push your cortisol levels slightly too high, causing steroid-induced anxiety and sleep disruption? Disentangling the psychiatric side effects from the endocrine interaction is incredibly difficult. You have two systems producing identical symptoms. I don't know, that feels too clean to me. The idea that we can just point to the enzyme and say that's the culprit. There are so many variables when you start an antidepressant. Serotonin receptor downregulation, neuroplastic changes. Pinning the physical discomfort entirely on a subtle shift in cortisol metabolism seems like a stretch.
It's not that the enzyme is the only culprit. It's that the enzyme is the ignored culprit. A psychiatrist might look at a patient sweating and shaking after starting fluvoxamine and immediately say, let's switch to a different SSRI. This one isn't agreeing with you. An endocrinologist needs to look at that same patient and ask, did we inadvertently increase their systemic steroid exposure? You're right that it's messy, but the article's point is that the interaction has to be on the differential diagnosis, because if you just keep swapping antidepressants without checking the cortisol clearance, you're treating the wrong mechanism.
Which brings us to the biggest blind spots of all, things you don't even need a prescription for. Grapefruit juice. I think people are broadly aware that grapefruit messes with medication, but they rarely connect it to their steroid replacement.
Grapefruit is fascinating because it contains compounds called furanocoumarins that irreversibly inhibit CYP3A4, primarily in the intestine. But research has shown it actually goes further than that with cortisol. Studies on patients with Addison's disease found that drinking grapefruit juice alongside their oral cortisone actually increased the cortisol available to their tissues. The juice enhances cortisol availability by inhibiting the CYP3A enzymes that would normally break it down, meaning a standard morning dose produces a much higher peak and a longer tail of exposure. You could take your hydrocortisone with a glass of grapefruit juice at breakfast and find yourself jittery and unable to focus by noon, completely unaware that your breakfast beverage just functionally increased your medication dose by 20%.
And the article touches on herbal supplements. St. John's wort acts as a strong inducer, tearing down cortisol faster. Licorice root does the opposite. Licorice is wild. It doesn't act on CYP3A4, right? It hits a completely different pathway.
Exactly. Licorice root contains glycyrrhizin, which inhibits an enzyme called 11-beta-hydroxysteroid dehydrogenase type 2. This enzyme's entire job is to deactivate cortisol by converting it into cortisone. It's a protective mechanism, especially in the kidneys, to stop cortisol from binding to mineralocorticoid receptors and causing severe sodium retention and high blood pressure. When you consume real licorice root, you block that deactivation. The active cortisol sticks around much longer. In a person with Addison's taking hydrocortisone, introducing licorice root can significantly increase their serum cortisol levels and drastically amplify the mineralocorticoid effects. It acts as a force multiplier for the steroids.
Wait, does that actually hold? Because if licorice blocks the conversion of cortisol to inactive cortisone, wouldn't that just be useful? Like, couldn't a patient use licorice root to stretch their medication further and avoid low cortisol dips?
That's a really dangerous game to play because the inhibition isn't precise. You aren't just stretching the cortisol. You're allowing it to flood receptors it isn't supposed to dominate. Chronic licorice ingestion causes pseudo-hyperaldosteronism. It mimics the effects of excess aldosterone. You get dangerous sodium retention, massive drops in potassium, and severe hypertension. It's not a gentle supplement that smooths out your cortisol curve. It's a biochemical override that can put you in the hospital with a cardiac event due to hypokalemia. The natural label gives people a false sense of safety.
That's a structural problem in how we talk about medicine. We categorize things by where we bought them. Prescription, pharmacy aisle, grocery store produce section. But the liver doesn't care if you needed a doctor's signature. It just sees the molecule.
Precisely. And that's the core message of the My Adrenal Life article. We have to strip away the assumptions about what counts as a real medical intervention. And over-the-counter NSAID like ibuprofen can alter how corticosteroids affect your stomach lining and kidney function. A cup of herbal tea can shift your enzyme activity. The burden of vigilance on the patient is immense. You aren't just managing the adrenal insufficiency, you have to become a pharmacist for your own life, cross-referencing every single thing that enters your mouth against your liver's metabolic pathways.
It requires a level of pattern recognition that is exhausting. When you feel a bad adrenal day coming on, you have to run a diagnostic tree. Did I sleep? Am I sick? Was I stressed? Did I take my meds on time? And now, did I start a new supplement 3 days ago? Did my other doctor change my asthma inhaler? It's relentless.
And the medical system isn't always set up to catch these interactions. An urgent care doctor treating a sinus infection with clarithromycin might not realize they are setting up an Addison's patient for a week of steroid overexposure. It's why that gentle reminder at the end of the article is so vital. It validates the physical reality of the patient's experience. When your body feels wrong after a medication change, it's not anxiety, it's not in your head. It is a highly specific, measurable shift in enzymatic breakdown. You have to trust that your perception of your body's stability is accurate.
The feeling of instability is real because the instability is real. The chemistry changed. We can map it down to the enzyme, down to the CYP3A4 activity, down to the half-life of the hydrocortisone. The math shifted.
Which means the solution isn't to doubt yourself, but to find the variable that changed the math. Whether it's grapefruit juice, an antibiotic, or a new prescription, the body is processing the replacement differently. Recognizing that is the first step to getting the stability back.
It's taking back the control of the narrative. The disease didn't randomly worsen. The environment around the medication changed. If this breakdown helped you see your own treatment protocol a little more clearly, Send it to someone else who might be staring at their pill bottles, trying to make the math work.